Good evening, everyone. I hope you enjoyed this week sessions, and tonight we'll give you the last two sessions. I'm Laurent Brochard, the Division Director of Critical Care in Toronto, and I'm going to present on patient ventilator synchrony or desynchrony. I already presented my conflict of interest. What I'm going to discuss is something which we have recognized over the last years and which is very frequent. In the ICU, most of the patients are what we call assisted by the ventilator. It means they are breathing, but their breathing is not sufficient, and the ventilator is trying to give in synchrony with patient's effort some assistance, either in volume or more frequently in pressure. So there should be a good synchrony between patient's respiration and assistance by the ventilator. In reality, this synchrony is not always good, and in fact, this is one of the main reasons to give sedation. We say it is to adapt the patient to the ventilator and to avoid desynchrony. But desynchrony on the ventilator is associated with a longer duration of ventilation and even higher mortality. So it's an association, but it says that there is something wrong here. And maybe it's also because we don't adequately manage the patients, either in terms of sedation or in terms of ventilation. The main characteristics of ICU ventilators is that they display waveforms on very visible and intuitive interactive screens. And since we have these screens and we see these waveforms, we have recognized more and more situations where the patient is not synchronous with the ventilator. And these waveforms need to be observed. Of course, you cannot spend 24/7 looking at the waveforms, but when you recognize some abnormal patterns, if you wish, we have to say, well, there may be some desynchrony. Can I do something about it? And what is the problem there? So when we say synchrony, this is what we don't see. This is the esophageal pressure indicating the respiratory muscle activity. And this would be a good synchrony. Like in pressure support ventilation, the patient would trigger and be assisted during the same time. That would be a good synchronous ventilation. But on the ventilator, you don't have this signal from the patient. So from airway pressure, but very often from flow signal, you have to recognize whether there's good synchrony or not. So why is that important? Why does it matter? Well, for two reasons. First, I said this asynchrony, desynchrony are associated with poor outcome. We don't know if it's a causal relationship, but of course it suggests that maybe we should try to have a better synchrony. But also it will help you to understand whether you give enough ventilation or too much ventilation. This is a schematic description of what we expect when the patient is on assisted ventilation. We expect that he has a normal work of breathing, because on the two ends of this curve, there is something which will go wrong. If the patient has not enough ventilatory support, he will be in respiratory distress, he will have increased oxygen consumption, he will have extra load on the respiratory muscle, very, very bad. But if the patient has too much ventilatory support, he will also do badly with ventilator-induced lung injury or associated lung injury and diaphragm dysfunction. And there are some asynchrony which are associated with excessive dose of ventilation, whereas other asynchronies are associated with insufficient ventilation. And when I say excessive or insufficient, I mean with regard to the needs of the patients. So it's interesting to understand the mechanism, because the asynchrony may be bad by itself, but also because it tells you whether you give the good dose of ventilation. So there are different types of dysynchrony. Clinically, they are detected by looking at the waveforms, or by alarms on the ventilator, or by agitation of the patient, but very often they are undetected. So I'm going to describe a 4-step process. The step 1 is to understand which type of dysynchrony it is and what is the mechanism. And to do that, you will have to understand to address 3 questions. How is your patient? Is he agitated, working hard, or at the contrary, looking very sleepy and very even sedated? And the parameter which can help you to understand that is the measure of respiratory drive, which we already discussed, which is the P0.1. And normal value would be between 1 and 3.5 centimeters of water. As you may remember, this is available on ventilator. So first question, how is my patient in terms of respiratory drive? Second question, well, how much ventilation do I give with regard to the patient needs? Do I give too much or not enough? And third question, how much sedation is this patient receiving? Too much or not enough? And of course, when I say too much or not enough, is with regard to the respiratory drive of the patient. Okay, after you understand the mechanism, then you adjust the ventilatory settings and you answer the question whether you need to increase the respiratory drive by decreasing ventilation or sedation, or decrease the respiratory drive by increasing ventilation or sedation. It may look complicated, but you will see there are very different situations and you will understand what it means. So the type of dysynchrony we are going to describe are very major dysynchrony. And this is one example of a patient who is on pressure support. This is the pressure curve on the top line. The second line is the flow. The third line is the volume. And in this patient, we have also the electrical activity of the diaphragm. Of course, we don't have that all the time. But when you look at what the patient is doing and looking at the electrical activity, you see that a number of breaths, effort done by the patients are completely missed by the ventilator. This is what we call ineffective effort or missing efforts. So the patient is doing an effort, but it's not triggering the ventilator. And we will see that this is caused by excessive ventilation. So this is a kind of dysynchrony we are going to talk, really very major difference between the timing of the patient and the timing of the ventilator. So let's go first to the situations where you have assistance in excess. And I will briefly talk about auto-triggering, which is a a very specific one, and then we'll go to apnea and ineffective effort. Auto-triggering means that the patient is receiving too much ventilation because the cycles are not triggered by the patient, but by something creating oscillation in the circuit. And for instance, it may be leaks, or in this nice example, when you look at the tracings, it was simply the cardiac oscillations. The cardiac oscillations of these patients were strong, and they were sufficient to trigger the ventilator. So this may be something you should think about when your patient is hyperventilated. The leaks are very frequent during non-invasive ventilation, as you can understand, and the ventilators have developed mechanisms to try to address this. Let's go into the synchrony created by excessive assistance, and I'm going to describe two: apnea and ineffective efforts. So this is the example of a patient who is receiving relatively large levels of pressure during pressure support ventilation. And in these patients, we have the recording of the transdiaphragmatic pressure and electrical activity of the diaphragm. If you look at the vertical line, you see that these patients, the tracings look very regular, look very nice, but this patient is doing a very, very small effort just to trigger the ventilator. And the rest of the ventilation is like pressure control, is like passive ventilation. And this patient is too much ventilation. And inevitably, if the patient tries to go to sleep, this is what will happen. The patient will become apneic. When you're awake,
Hi, everyone. Sorry for the technical difficulty. We'll be back online shortly.
Okay, sorry for the interruption, and I hope you can still hear me well. So I was describing these tracings where you see the patient becoming apneic for maybe 15, 20, 25 seconds. And we have realized that many patients, when they go to sleep with pressure support, and receive a little bit too much of ventilation with a little bit to low PCO2, they become apneic. And one of the problems, next slide, is that the apnea are associated with arousal or awakening. So the paradox is that the patients go to sleep, become apneic, and then are awake by this apnea. So this is very, very bad because the patients are continuously trying to go to sleep and are never able to reach a deep sleep. So whenever you see a patient becoming apneic during pressure support ventilation, the main reason is that he's receiving too much ventilation. So it's very important because it can really generate major sleep disruption. On the next slide, you see the other problem which can occur, and I put on this slide either pressure support or assist control, which is called ineffective efforts, and we have seen that before. So you see that the patient is doing small efforts which are not triggering the ventilator, and the way to detect it is to look at the airway pressure tracing, the first waveform, or more often easier to see on the flow tracing. During the expiratory part, you see these small bumps which indicate the patient is trying to inspire but is not triggering the vent. Let me go to the next slide, and this is an example where you see the tracings. It's not easy to see, but on the flow you see this small change in the flow curve. And on the next slide, maybe you have to click 2 or 3 times, you will see with the electrical activity of the diaphragm that the patient is breathing much more frequently than what is detected by the ventilator. So the real respiratory rate of the patient is not 18 as indicated on the ventilator, but it's probably 35 or 36. Okay, so the reason why it happens, it's because the patient is hyperinflated. So when you see that, you should say, well, I should try to reduce the pressure support. The patient is receiving too much. The next slide is a study which show that there are different ways to reduce this asynchrony, and the 2 simplest way is to decrease pressure support or increase the flow criterion to switch from inspiration to expiration, what we call optimal TI. So if you click 3 times here, you will then go to the next slide, which show an example where the patients who had a lot of asynchrony, the asynchrony index, I hope you see that on the good slide 23. The asynchrony index is very high, and just by decreasing pressure support, many patients had no asynchrony anymore. The next slide, 24, is now showing the desynchrony, the characteristic of this desynchrony related to excessive assistance. Don't think that the patient is fighting or struggling. In fact, those patients are very often look sleepy, and they have a low respiratory drive. That's why when you have a desynchrony with a low respiratory drive, you have to try to increase this drive by either decreasing ventilation or decreasing sedation. Next slide, called insufficient assistance. It's a situation where the ventilator is not delivering what the patient wants, and the patient is trying to get more. So the classical situation is what we call air hunger or flow starvation, and the consequence of that can be double triggering, breath stacking, and short cycles. Next slide. This is an illustration of assist control ventilation. This is one breath which is passive, and the next slide shows the same breath delivered by the ventilator when the patient is actively breathing. And the next slide superimposes the two breaths. So it shows that the effort generated by the patient, which is indicated by the bottom recording, the esophageal pressure, is directly transmitted to the airway in case of volume control. Next slide. And it's very important to know that the main reason why patients may have flow starvation during volume control is when the peak inspiratory flow, which is a setting on the ventilator, is not sufficient. You see here an example where the peak inspiratory flow rate is decreased below 55 liters per minute to 45 to 35, and the work of breathing of the patient is increasing. Just think that the patient is not receiving enough, so he's struggling and is really looking bad. Next slide. When the patient is working more than what the ventilator is delivering, there can be evidence of poor synchrony because the patient will continue to inspire at the end of insufflation. And you may have these funny tracings where the flow is quasi interrupted at the beginning of the expiration, or is triggering a second breath, and that's what we call double triggering. Next slide, we can skip this one. And next slide, it shows a tracing from a recent study in patients with ARDS, for instance, showing example of one patient who had a lot of this double triggering with breath stacking. And when you look at the last tracing with the red arrows, show you very well that the volume is going up very much. And of course, when we want to control the volume, this is very bad because this gives much more volume than the 6 ml per kilogram which are set on the ventilator. It may be 12, it may be sometimes 18 milliliters per kilogram. So very, very bad situation. Next slide. What I've been describing to you is mostly during volume assist control, because as I said, during volume assist control, the patient effort is directly transmitted to the airway. During pressure assist control, you can have also double triggering, but you don't have the same consequence of an effort because the ventilator will increase the flow to maintain the pressure. And therefore, in pressure assist control, you will not have the deformation of the airway, but you will have much higher tidal volumes. So as a clinician, you have to decide whether if you want to control tidal volume, you need to keep volume control. But if the volume control is associated with breath stacking, that's not good, and you may need, for instance, to sedate, to give more sedation to your patient or even paralysis. Next slide. So these are examples where the synchrony is related to insufficient assistance. The patient is working hard. The respiratory drive is high. Maybe the P.1 will be higher than 3.5 or 4. And so you have to think, can I increase the assistance, increase the flow, maybe increase the PEEP, increase FiO2, increase ventilation, or should I increase sedation? Next slide, I'm going to finish with the last desynchrony, which is very frequent and which we call the reverse triggering or respiratory entrainment. Next slide. So this started with an accidental observation. When we looked at a patient who was on pressure control, and if you click here, you will see what's happening with the, maybe go to the next slide. This patient was on pressure control, looked like being passively assisted by the ventilator, but at every breath, there was a diaphragmatic contraction, which is illustrated here by the activity of the diaphragm on the bottom tracing. But the surprise was that this activity of the diaphragm was not triggering the ventilator. It was like the opposite, like the ventilator triggering the diaphragmatic contraction. And in these patients, when the rate on the ventilator was changed, the rate of diaphragmatic contraction also changed. So it was the ventilator triggering the patient. That's why we called it reverse triggering. On the next slide, and you have to click once more, you will see that the first consequence of that can be to increase tidal volume. Next slide, or can be to induce double cycling. So this is where the situation is different from what we've just seen before, and we call double triggering, because the first breath is not triggered by the patient. The first breath is a mechanical ventilation breath, followed by this contraction. Here, the last waveform is not the diaphragm, is the esophageal pressure, and you see this huge contraction with the dip in the drop in the esophageal pressure. So, very interesting phenomenon which we observe very often in patients sedated. Their diaphragm is following the activity of the ventilator and can induce, for instance, these double cycles. Next slide, let's skip this one. Next slide, this is just to show an example of a patient having a lot of this double triggering. And it may not be easy to distinguish whether it's double triggering with high respiratory drive or double cycling. So this desynchrony related to reverse triggering occurs in patients who are sedated, who have a high respiratory, no respiratory drive because they are sedated. And therefore, in this situation, you may say, maybe I need to decrease sedation, so to let the patient take the control of the ventilator, or sometimes to increase ventilation because it may be associated with insufficient ventilation. Okay, so remember these three examples. The examples with excessive ventilation, apnea, ineffective triggering. The examples with insufficient ventilation, short cycle, double triggering, breath stacking. And the third example of reverse triggering in sedated patients where maybe it's related to too much sedation. Next slide. I will stop there. And this is one of the websites where you can find information about these questions. And for instance, in this blog, we posted something on reverse triggering. So I will stop there and be happy to address any questions. Okay.
Super. Thank you very much, Laurent. Just waiting to see if questions come in here. Laurent, maybe while we're waiting for questions, do you want to just describe sort of what your routine assessment of a ventilated patient is looking for desynchrony? You know, what's your habit? Do you inspect the waveforms frequently? Just what's your general approach?
Yeah, that's a great question. So it depends on the type of patients, and because what I describe is kind of three types of situations. So the patient who is sedated, I will look for reverse triggering by looking at the expiratory flow waveform and the pressure waveform. And again, when you think about it, you see it very often. And when you see that, maybe it's an indicator that it's time to decrease sedation. Then the second circumstance is the patient who has been very hypoxemic, very severe, and the patient has been sedated, but you're not sure the sedation is appropriate. And then you look at a patient who is triggering every breath, doing effort, and you try to see if there is this double triggering and breath stacking. The third situation would be the patient put on pressure support ventilation and maybe looking very quiet and not struggling. Then I will look for these ineffective efforts by looking at small changes in the expiratory flow. And every time, looking at the ventilator waveforms will give me the solution.
Okay, great, thanks. Here's a question. What would be your approach to correct double triggering?
Oh, that's a great question because the answer is not easy. So the principle in double triggering is that the patient is doing an inspiration which is longer than the insufflation delivered by the ventilator. So I will try to lengthen the insufflation. The problem with, for instance, if it's square flow and if I decrease if I increase the inspiratory time but keep the same tidal volume, I will have to decrease the flow, which may not be well tolerated. So what I try to do is to switch from a square flow to a decelerating flow, which is available on most ventilators. And the ventilator will keep the same peak flow, but will prolong the insufflation. So that's one thing. The second thing is to be sure to add a pause at the end of insufflation, which again will prolong the inspiratory time, during which the patients could trigger a second breath. So with the decelerating flow with a pause, usually you stop the double triggering. The next question is, do you think the patient is comfortable enough? And if the patient looks okay, you can continue like that. But if he looks really struggling a lot, you may need to give more sedation.
What do you think about just switching to pressure control in that situation?
So pressure control will probably make the patients more comfortable because the flow will not be limited. So if the patient is making a huge effort, the ventilator will just maintain the pressure by giving more flow. The big issue with that is that you will not be able to control the volume anymore. And we have examples of patients switch to pressure control or pressure support who looks less desynchronous, but who are taking huge tidal volumes, which we know are dangerous for the patients. And these are situations where you may have the risk of self-inflicted lung injury.
Question here. If you have ineffective efforts because of hyperinflation, should we decrease the PEEP instead of the pressure support?
That's a good question. So the PEEP, in fact, does not play a big role. Some people have said maybe we should increase the PEEP because hyperinflation means intrinsic PEEP, which is true. But that's a good point to say, well, hyperinflation also means too much pressure, and then we should decrease the PEEP. But the problem of this hyperinflation is related to the pressure you give during the inspiration. And the excessive pressure support will make the patient hyperinflated at the end of inspiration, and the patient will not have enough time to expire. So although the question is very clever, but the good answer is really to give less ventilation to the patient.
How do you think about managing pain or analgesia in the context of dysynchrony? Sometimes, you talk about low respiratory drive or high respiratory drive, and sometimes management of pain and analgesia has an effect in that situation. Are there any sort of priorities that we need to think about?
Yeah, that's a good point. So I think if you have pain and you probably will end up with a high respiratory drive, which you can see on the ventilator with high levels of P01. And then managing the pain may help to reduce the synchrony. The problem is that we tend to give sedation, and I say sedation because we give analgesia and sedation sometimes not very with a very clear goal to reduce desynchrony, but I don't think it's right because, for instance, ineffective effort is often increased with sedation. And also this discussion of the short cycle and double triggering, which we discussed, can be solved by adjustment of the ventilator instead of giving more sedation. But controlling the pain makes sense. Over sedating the patients does not.
Okay, thanks. Some questions here about reverse triggering. What's the difference between auto triggering and reverse triggering?
So auto triggering is something which is not coming from the patient. Auto triggering means there is a signal interpreted by the ventilator as coming from the patient, but which is not, well, coming from patient's effort, but which is not patient effort. For instance, when you have triggering based on flow, if you have any leak in the circuit, well, this leak will be interpreted by the ventilator as the patient's effort. So there will be, that's where we say there is auto triggering. And when I showed the cardiac oscillation triggering the ventilator, this is again auto triggering because it's not patient's inspiration, it's another signal. What we call reverse triggering is the situation where the ventilator is doing a good job at giving breath in volume or in pressure, but this mechanical insufflation is triggering the patient's effort, like a reflex, if you wish. Like if you start to give volume into the patient's chest, and at some point, maybe near the end of inspiration, it induces a diaphragmatic contraction. We don't know exactly why. There are probably different mechanisms, but it's a situation where the ventilator is inducing a contraction of the respiratory muscle of the patient. And this contraction, which arrives very late in the breath, we call it reverse triggering, and sometimes this reverse triggering can trigger a second breath, which we call then double triggering and breath stacking.
Super. Some really thoughtful questions here about respiratory monitoring. Do you routinely use an esophageal pressure monitor?
So we have used a lot the esophageal pressure monitoring to understand this phenomenon, and we have been doing studies, and this has been super useful. However, we now are used to recognize many of these asynchronies just looking at the waveform, and just to help us, we use the tools that we have already described, the P01 or the POCC, the occlusion maneuver, which tell us what the patient intrinsically is doing. Is the patient is doing very small efforts with a low drive, or at the contrary, is the patient doing very high effort with a high drive? So using both the waveforms, the classical waveforms, plus these two maneuvers, we are able to answer most of the situations. Of course, if you have esophageal pressure or electrical activity of the diaphragm, it's even easier because you directly see what the patient is doing compared to what the ventilator is doing.
That's great. How do you measure total PEEP for a patient with high respiratory drive? How would you measure respiratory mechanical parameters like airway resistance or respiratory system compliance? Is there a way to do that in a patient with high drive?
So it is, of course, complicated because the easiest way is when you have a passive patient, is not doing anything, and you do the occlusion and inspiration and expiration, and you have very nice parameters and very reliable. When the patient is breathing, that is much more difficult because the occlusions may occur while the patient is inspiring, or at the opposite, the patient is expiring. So for instance, measuring auto-PEEP is very tricky because if you do an occlusion at the end of expiration, well, you will do the maneuver that we discussed, the POCC. So you will see first a very large drop in pressure. And then at the end of this drop, the pressure will go up and will go to a certain positive value, which may be intrinsic PEEP. But at that time, the problem is that it may also be expiratory muscle activity, and it will be very difficult to compare. So measuring auto-PEEP is very difficult. What is very interesting is that, by contrast, doing an N-inspiratory pause, like the one you do for measuring a plateau pressure, seems to be very feasible even during pressure support. So it's not possible on every ventilator, but on several ventilators, you can do an N-inspiratory pause, hold, and surprisingly, you will see that the patient will stop breathing. This is a reflex called the Herring-Burr reflex. You stop inspiring when you are at high volume, and you may have maybe in 3 patients over 4, you may have a good plateau, which you can interpret and use to measure your compliance and elastance.
Super. Super. I think that's all the questions we have time for at this point. There's a number of questions asking about the website where we'll be posting all these slides. And it's unfortunately, I have no way of typing out the name of the website, but it's criticalcarecanada.com. criticalcarecanada.com. All of our slides will be posted to that website within 24 hours. All right.
Okay.
So Laurent, okay if I move to my presentation?
Absolutely. Thank you, Yuan.
All right. So I'm just going to share my screen. Okay. And then I'm going to play my slides. All right. So I'm going to wrap up our series of talks with a presentation on liberation from mechanical ventilation. So this is the part where the patient's starting to recover, turn around, and now the clinical challenge is not just to keep them alive and not just to avoid injury to the patient while you're set in the ventilator, but to get them off the ventilator. And sometimes this can be a challenging process. So I want to spend the next 30 minutes basically explaining the basics of the process and giving you a framework for thinking about what to do if a patient is difficult to liberate from mechanical ventilation. These are the disclosures I mentioned a couple of days ago. So a classic paper that introduced the term liberation from mechanical ventilation was written by Jesse Hall and Larry Wood in JAMA back in the 1980s. And I like to kick off this talk with this quote because I think it's helpful for conceptualizing the problem of getting the patient off the ventilator. And they wrote, "It is somewhat misleading that the term, quote, weaning has come to describe the continuation of mechanical ventilation, since to physicians without extensive experience treating mechanically ventilated patients, an analogy may be construed to separating a deprived patient from a nourishing ventilator." And of course, I pointed out that the idea of weaning is often used to refer to a child nursing its mother. And of course, the ventilator is not a source of nourishment. It's a potentially injurious instrument that we use to sustain gas exchange, but has lots of complications associated with it. And so the faster you get off the ventilator. Moreover, the process of getting the patient off the ventilator is not as gradual as what weaning would imply. When you wean a drug or other therapies, wean pressors, you typically do so gradually over an extended period of time because the patient has become somehow dependent on the drug, whereas many ventilated patients are ready to be liberated after they've recovered from their primary insult. And so the task of the clinician is to recognize at the earliest possible opportunity when they can separate the patient from the ventilator, and in so doing liberating them rather than just weaning them over time. So when I'm on rounds, I like to present a basic framework for a daily assessment of a ventilated patient. And to me, this involves asking myself 3 questions. First, is the ventilation safe? Secondly, is the ventilation adequate? And then third, is the ventilation necessary? So we've spent time talking about safety and adequacy. Safety, of course, being these issues of dysynchrony, lung injury, diaphragm dysfunction, adequacy being the question of gas exchange and just sustaining the patient. But the question of necessity is important for us to ask, because if we forget to ask it, sometimes we'll fail to recognize that a patient's actually ready to be taken off the ventilator. So how does this work? So basically, patients proceed through a very typical course when they are on mechanical ventilation with respiratory failure. In the early course, they have relatively severe illness. They have significant impairments in gas exchange and potentially respiratory mechanics, and so they definitely need to be on the ventilator. And then they turn a corner and they start to improve. Their oxygen requirements start to come down. Their ventilatory pressures start to come down. You're able to wean the sedation and initiate spontaneous breathing. And so then the question becomes, how do we recognize when a patient is ready for a weaning or liberation trial, also known as a spontaneous breathing test? What do we look out for to decide that we can potentially test for weaning? And then if they've reached the stage where they actually are past a weaning trial, then the question becomes, are they ready to be extubated? And so those are the first basic questions I want us to think through, how we actually do that. So there are some basic criteria that we use to assess whether a patient is potentially ready for liberation. The first thing, of course, is that the primary cause of respiratory failure has resolved or is at least resolving. So, and that's really a clinical judgment that you make based on the overall course of the patient in terms of their gas exchange, their hemodynamics, their level of consciousness. Really depends, of course, on why they were intubated and put on a ventilator in the first place. But your general sense as the bedside clinician is that the patient's getting better. Then the next criterion is that they have stable respiratory status. They're not that hypoxemic. Their FiO2 is no higher than 0.4 to 0.5. Different centers use different criteria, so this is why I'm putting some ranges here. But they're not that hypoxemic. Their PEEP is not that high. Again, typically centers will use 8 or 10 as a maximum level of PEEP for doing a spontaneous breathing test. And of course, the patient has to actually be breathing. They have to be triggering the ventilator and making spontaneous respiratory efforts in order to do a spontaneous breathing test. One other piece of being ready for liberation is that your hemodynamics are stable. You're on a relatively low dose of a single vasopressor, and clearly your shock state is resolving. Patients don't need to be off pressors entirely, of course, but they do need to be improving, because you do not want to destabilizing them by imposing the respiratory load back onto the respiratory muscles and respiratory system. So how do you do a liberation trial or a spontaneous breathing test? Well, you can think of it as kind of like a driving test. You sort of put the person in the car and see how they do. And so basically the concept is that we reduce the ventilator support to the absolute minimum and see how they respond. Can they tolerate the work of breathing without support from the ventilator? Can they maintain adequate oxygenation without support from the ventilator? Does their CO2 go up? Do they become distressed? Does their level of consciousness go down? These are all the kinds of things that you look for to see that a patient's breathing comfortably and spontaneously during the spontaneous breathing trial. Now, I should mention that there are different ways of doing a spontaneous breathing trial. Different people have different conceptions of what minimal ventilator support is. And I think both Professor Brochard and I would recommend a true minimum, which basically means no inspiratory or expiratory support during the spontaneous breathing trial. So we take a patient and turn the airway pressure all the way down to 0. So they're on a CPAP of 0 centimeters of water. They're getting no inspiratory support, no expiratory support. And that's a true test of the patient's ability to sustain the load of breathing. Now, other centers will recommend some inspiratory augmentation, inspiratory pressure augmentation, for example, a pressure support of 5 or 7 on a PEEP of 0. And still others will use a low level of CPAP during the spontaneous breathing trial. So this is an area of some practice heterogeneity. It's an area of minor controversy. But the important point is that you're basically letting the patient go and seeing how they do on a minimum tolerated, on a minimum level of ventilator support. Now, how do you tell if they pass the test? What are some criteria? Well, of course, as I mentioned, you don't want them to be developing respiratory distress, or clearly they're not ready to be liberated from the ventilator. If they desaturate and have low oxygen levels, they're not ready to be liberated from the ventilator. If they become hypotensive or hypertensive, they may not be ready to be liberated from the ventilator. And that hypertension often reflects the significant sympathetic stress associated with spontaneous breathing. So even though hypertension in and of itself may not be dangerous, it reflects the fact that the patient's system is significantly stressed by the spontaneous breathing trial. You can think of a spontaneous breathing trial kind of like a cardiac stress test in some respects. We'll talk about that more momentarily. So that's how you do an SBT, and this is what you look for. Now, probably the best validated criterion for passing the test is what we call the rapid shallow breathing index, or the F, the ratio of respiratory frequency divided by tidal volume in liters. And so this will range anywhere between 30 and 200, depending on how the patient does. And the lower, the better. Lower means that the respiratory rate is lower and the tidal volume is higher. So it's a way of looking for rapid shallow breathing pattern. And I should point out that this test is really validated for the true minimum ventilator support level, TPs or CPAP of 0. That's when the rapid shallow breathing index is most reliable. And typically what we want to see is that a patient's rapid shallow breathing index is less than 100 to say that they're probably going to do well after being extubated and can survive without ventilator support. Now, once they pass the spontaneous breathing trial, there's some additional questions, of course. It's not just a matter of separating from the ventilator, but of taking out the endotracheal tube. And so you have to assess, are they ready to be separated from the ventilator? Did they pass their spontaneous breathing trial? But also, are they protecting their airway? Are their airway reflexes intact? Are they sufficiently awake to protect their airway? Do they have a reasonable cough and ability to clear secretions? Are their secretions and sputum production excessive such that they're just going to plug up and develop respiratory distress? And of course, your general assessment of their clinical stability and improvement. You don't want to extubate a patient when they're possibly deteriorating overall. And sometimes we'll use something called a cuff leak test, which basically is a way of testing for the development of edema in the trachea at the site of the inflated cuff on the endotracheal tube. And this test is of relative use when you have a high suspicion that the patient might have tracheal edema, which typically develops over days when an inflated cuff is applied against the trachea. And so to do the test, you deflate the cuff and see if the patient can move air in and out of the airway around the endotracheal tube. So you're actually plugging the endotracheal tube and looking to see if they can move air around the endotracheal tube. And if they can, then you know that there's not significant edema around the endotracheal tube, and that you can take out the tube. Now, sometimes even when patients have no cuff leak, that is, you're wondering about edema, if they've only been intubated for a very short time and the risk of edema in the trachea is low, then you can comfortably take out the tube anyway. So this is just one piece of information that we use to decide whether a patient's ready for extubation. So that's the basic process, and this process here, the process is summarized in this figure here. Data on weaning outcomes from Laurent Bouchard's collaborators in France, where they looked at the time course of weaning from mechanical ventilation. So they, and it's interesting to look at how the risk of death varies according to the duration of weaning. So if you're placed on invasive mechanical ventilation, but you never make it to a spontaneous breathing trial, then your risk of death is, of course, very, very high. That's why you wouldn't make it to a spontaneous breathing trial, because you died. But if, on the other hand, you have a spontaneous breathing trial and you're extubated within 24 hours without another trial, then your risk of death is very, very low. And on the other hand, if you fail an SBT repeatedly for up to 1 week, then your risk of death is considerably higher, around 16%. And if you take more than a week to wean from mechanical ventilation, you're having daily spontaneous breathing trials, you're failing them repeatedly, and you're still stuck in the ventilator after a week of weaning attempts, then your mortality is very high at 30%. Now, of course, sicker patients will have a more difficult time being liberated from the ventilator, but the important point here is that patients who require more prolonged time on the ventilator have a higher risk of poor clinical outcome. And it's not just a risk of death that we're concerned about, but also of long-term functional disability. So in studies looking at patients who are liberated from the ventilator, but only after at least 21 days of mechanical ventilation, you see that the rates of functional dependency are very, very high. So in this cohort, more than a third of patients were alive with complete functional dependency at 3 months, and many of those either died or failed to improve at the 12-month mark. And other patients who initially had better functional status subsequently deteriorated. So these patients are very high risk for prolonged disability. And in other studies, such as data from Carol Hodgson here, it's been shown that the number of mechanical ventilation days is an important independent risk factor for the development of long-term disability after mechanical ventilation. So the message is it's important to get patients off as rapidly as we can, because the longer they're on the ventilator, the higher the risk of long-term disability. So what is it that makes a patient dependent on a ventilator? Well, you can think of difficult weaning and respiratory failure in general as a problem of supply and demand. So the patient has respiratory loads placed on their system that reflect the mechanics and the dead space and the rate of CO2 production that needs to be cleared and other imposed loads. And then they have the capability of their system, their respiratory muscle strength and their respiratory drive. And if the demands on the respiratory system exceed the capabilities of the system, well, then you're going to remain stuck on a ventilator. So in assessing the difficult to wean patient, we want to try and understand what are the demands placed on the system and what's the capacity of the system to tolerate that demand. So that's how we're going to approach this problem of difficult liberation from mechanical ventilation. Now, the first major cause of difficult liberation from mechanical ventilation, and by this I mean you have a patient who met readiness to wean criteria. They were doing well. They underwent a spontaneous breathing trial, but they failed. They immediately became distressed over a period of several minutes, and it was clear that they weren't ready to be liberated from the ventilator. So what's our approach to assessing and managing that kind of patient? What can we do to help them get off the ventilator? And the basic approach I'm advocating for is trying to understand the exact mechanism that is the reason why they're still on the ventilator. So the first and most common cause of a failed spontaneous breathing trial is actually heart failure, not lungs, not respiratory muscles, but actually cardiac failure. And why is that? Well, I showed this image the other day in the course of our discussions about the potential risks and complications of mechanical ventilation. And we talked about the fact that while positive pressure ventilation is not so good for the right ventricle most of the time, it's actually something that the left ventricle loves. And this is because applying pressure on the outside of the left ventricle makes it easier for the left ventricle to do its job, which namely is to squeeze the blood out of the left ventricle and into the aorta and systemic circulation. So when you apply positive pressure outside, you're reducing afterload. But what that means conversely is that as you reduce positive pressure ventilation, you actually increase afterload. Now the left ventricle has to work harder to drive blood out of the left ventricle and into the circulation. And in particular, once you take a patient off of a ventilator and put them on a spontaneous breathing trial, now instead of having positive pressure pleural swings, they will have negative pressure pleural pressure swings. And so this can dramatically increase afterload, because your pleural pressure can go from positive 10 to minus 20, minus 30 if you develop respiratory distress. So that's a 40 centimeter of water swing in pressure. That's a significant increase in left ventricular afterload. And so many of these patients can acutely decompensate if they're volume overloaded, if they have some element of systolic or diastolic dysfunction. They can decompensate and go into left heart failure acutely during the SBT. And in fact, that is the most common reason for a failed SBT. So there's nice physiological data highlighting the impact of negative intrathoracic pressure on left ventricular performance. So these are echocardiographic measurements made during a Muller maneuver. So the glottis is closed, and then the subject makes a vigorous inspiratory effort. And what you can see during the vigorous inspiratory effort, if you look first on the right, you see that the ejection fraction acutely drops significantly from baseline. So the Muller maneuver is actually acutely reducing left ventricular contractility. And then it's also increasing end diastolic volume, as you can see in the figure on the left. During the Muller maneuver, end diastolic volume actually goes up. So the ventricle's ability to empty is acutely impaired. So this highlights the hemodynamic effects of transitioning from positive pressure ventilation to the usual negative pressure ventilation mechanism of the respiratory muscles. And these tracings here show what it looks like when a patient goes into acute pulmonary edema during a spontaneous breathing trial. So if you start out at a baseline before the patient's put on the weaning trial, you have tracings of esophageal pressure, and that's represented as PESO, and then you have tracings of pulmonary arterial occlusion pressure, or the wedge pressure, which is a surrogate for left atrial pressure. And so you can see that every time the patient makes it, or every time the ventilator drives positive pressure in, the esophageal pressure goes up and the wedge pressure goes up with each breath. But then you take the patient off the ventilator and do a spontaneous breathing trial. And at 5 minutes, now we're looking at the tracings in the middle, you can see, first of all, that the esophageal pressure swings are now lower and much more vigorous. So the patient's making large inspiratory efforts, which means you have these large negative deflections in esophageal pressure with each breath. And during that, you can see above that now the average pulmonary arterial occlusion pressure has significantly increased. And you can also see the large intrathoracic pressure swings reflected or transmitted into the wedge pressure. And at 9 minutes, the wedge pressure is even higher. And so the patient's progressively going into acute left heart failure and acute pulmonary edema. And interestingly, at the 9-minute mark, you see the swings in esophageal pressure are actually attenuated, which suggests that possibly this patient's developing acute respiratory muscle fatigue. So this is the classic pattern of weaning-induced pulmonary edema. So how can we recognize this at the bedside? How can we diagnose weaning-induced pulmonary edema? I would point out that systematic studies suggest that approximately 60 to 70% of failed spontaneous breathing trials are a consequence of weaning-induced pulmonary edema. So this is a very important mechanism that needs to be addressed clinically. So how do we make the diagnosis? Well, there's a number of tricks that basically rely on detecting hemodynamic responses. And one such trick is to perform a passive leg raise. So the basic idea here is that if a patient has a significant increase in cardiac index during a passive leg raise, then that implies that their baseline venous return is relatively lower. And so during the spontaneous breathing trial, their left heart pressures are not going to go up as significantly because they're not volume overloaded. Whereas if a patient has no passive leg raise, no augmentation of cardiac index with passive leg raise, then that patient is probably at a relatively high point on the Frank-Starling curve at the onset of the spontaneous breathing trial. And so they're more likely to go into weaning-induced pulmonary edema during the spontaneous breathing trial. The physiology is slightly more complicated than that, but we don't need to get into venous return curves and so on. The point is simply that if you're volume overloaded at the start of your SBT, and as reflected by an absence of passive leg raise response, then you are probably have weaning-induced pulmonary edema as the cause of your failed SBT. You can also actually see this on ultrasound during the SBT. So these are, I'm not sure how many of you are used to using lung ultrasound, but these are fairly typical pictures of lung ultrasound images. So if you look at the set of 4 images on the left, you have 2 images of the right lung and 2 of the left. The upper row is for the upper anterior region, and the lower row is for the lateral region. And what you'll see in those images is these horizontal lines. Those are called A lines, and those are basically normal artifact of air in the lung, which is what you expect to see, air in the lung. So when you put the ultrasound probe on, you see A lines, that's a normal image. But when you repeat the ultrasound, the lung ultrasound, at the end of the spontaneous breathing trial, you can see that now there's multiple what are called B lines in the same images. So instead of the horizontal lines, we have these vertical lines that reflect out from the probe. And these are markers of the development of pulmonary edema. So these images here show us that the lungs have actually become edematous during the spontaneous breathing trial. And this is an easy way of confirming the diagnosis of weaning-induced pulmonary edema. Now, to be honest with you, most of the time I don't trouble myself to do these diagnostic maneuvers, because if somebody fails an SBT, well, the thing I'm most suspicious about is automatically weaning-induced pulmonary edema. And so the priority is to diurese these patients as much as possible. And interestingly, this trial that Laurent Brochard and colleagues published shows that when you measure BNP daily and use that to guide your fluid management, the BNP-guided weaning arm had much more diuresis than the usual weaning arm, and those patients were weaned significantly faster. And I'm not making the case here for using a BNP to guide your weaning, but rather to highlight the fact that it seems that a more aggressive diuretic strategy during the weaning phase can accelerate liberation from mechanical ventilation, and particularly in patients with known LV dysfunction. So I think the first thing to do that makes most sense whenever you have a patient who fails an SBT is to make sure that you can diurese them as aggressively as possible to try to liberate them from the ventilator. The second main cause of difficult weaning from mechanical ventilation is respiratory muscle dysfunction. And the respiratory muscles, of course, are the respiratory pump. They're the ventilator that you use when you're not on a ventilator. And so if those muscles become weak, and in particular the diaphragm is the primary muscle of inspiration, then you're going to have significant difficulty getting off the ventilator, as we discussed the other day. So there's evidence that patients with diaphragm weakness are at very high risk of developing difficult weaning, prolonged weaning, or dying in hospital. So if you look at this figure, the y-axis is the percentage of patients who have the outcome, whether difficult weaning, prolonged weaning, or mortality. And the patients in the pink bars are those with diaphragm or limb muscle weakness. And the patients in the turquoise bars are patients with no diaphragm or limb muscle weakness. And as you can see, the patients who have diaphragm weakness are at far higher risk of difficult weaning, prolonged weaning, or hospital mortality in comparison to patients without diaphragm weakness. And this association was much weaker for the limb muscles. In fact, it wasn't significant. So this reinforces the idea that the diaphragm is a key determinant of your ability to be liberated from the ventilator, and that if you end up getting stuck on the ventilator, then your risk of dying in hospital is much larger. We also recently published some data that interestingly show that the thickness of your diaphragm at the time of being admitted to the ICU actually strongly predicts your ability to get off the ventilator. So this is the diaphragm thickness on the x-axis measured within 36 hours of being admitted to the ICU. And as you can see, patients with a thin diaphragm are at much higher risk of developing complications of respiratory failure or requiring prolonged weaning in comparison to patients with thick diaphragms at baseline. So the function and the structure of the muscle appear to have a strong impact on the patient's overall outcome. So how can we assess the diaphragm at the bedside? How do you determine if a patient who fails an SPT has diaphragm dysfunction? Well, ultrasound has really made this very easy, and I'm not going to go into the details here, but you can very basically assess diaphragm function by measuring the excursion of the muscle, by visualizing the movement of the dome of the diaphragm during the spontaneous breathing trial. I would emphasize that this measurement has to be collected during a spontaneous breathing trial, because if the patient's on any inspiratory assistance from the ventilator, then you'll have diaphragm excursion without actual muscle effort. So in order to visualize the function of the muscle, you have to do this measurement during a spontaneous breathing trial. But in doing so, you can readily see if the muscle is moving, and if it's not, then that is diagnostic for diaphragm dysfunction. So during resting quiet breathing, the excursion of the dome should be at least 1 centimeter, and if it's less, that would be diagnostic for diaphragm weakness. Another measurement that you can use is to actually visualize the thickness of the diaphragm in cross-section. And again, I won't get into details here, but the basic idea is that you can see the muscle in cross-section, and as it contracts, the muscle thickens, just like any muscle that shortens has to thicken. And you can quantify that thickening in M mode, as shown here on the right. And this allows us to measure the contractility of the diaphragm. So if a patient's on a spontaneous breathing trial and you put the ultrasound probe on and you see no thickening of the diaphragm, or the thickening of the muscle is less than 20% of its baseline thickness, then that's diagnostic for severe diaphragm dysfunction. And these measurements of diaphragm thickening have been valid against sort of classical gold standard measurements of respiratory muscle strength based on twitch pressures, which are much more difficult to obtain. And a diaphragm thickening fraction below 30% strongly predicts difficult weaning from ventilation and is diagnostic for diaphragm weakness. So this is an easy to use tool at the bedside to assess for the possibility of respiratory or diaphragm muscle weakness as a cause of difficult weaning from ventilation. So what can you do about it if a patient has difficult weaning? Well, I won't get into details here, but just to let you know about this, and you can look more into the literature on your own. There's a very nice review on inspiratory muscle rehabilitation that was published in Critical Care just a couple of months ago, and we published a systematic review a couple of years ago, which demonstrated that the routine use of inspiratory muscle training can actually increase inspiratory muscle strength and may potentially accelerate liberation from the ventilator. So these are very useful techniques that are very easy to apply at the bedside. So other. So I say other here because basically I think honestly that weaning-induced pulmonary edema and diaphragm weakness cover probably about 85 to 90% of difficult weaning from mechanical ventilation. Sometimes other mechanisms can contribute or exacerbate these problems. And this is a very nice review that Laurent wrote actually several years ago now, but it still, I think, is the one I like to refer to as a kind of detailed and very helpful clinical summary of all the issues. So the patient's brain dysfunction from delirium and agitation can exacerbate difficult weaning. Of course, abnormal respiratory mechanics, if the lung mechanics haven't resolved completely, may contribute to difficult weaning. If a patient has weaning-induced pulmonary edema, they may in fact have coronary artery disease that's being unmasked by the weaning trial. And so cardiac ischemia is something that needs to be considered, a whole range of issues. And so I'd recommend this paper to you as one that you can refer to when you're assessing patients who are difficult to liberate from the ventilator. And just a quick word on assessing respiratory mechanics. So how do you actually go about determining if a main reason that the patient can't get off the ventilator is because they're lungs are still too stiff. Well, it's essentially a matter of measuring the driving pressure. So if the driving pressure remains very high in a patient who's on relatively low ventilator support, that just means that their respiratory muscles can handle a lot of the work of breathing, but their mechanical load may be such that they're still not ready to be liberated from the ventilator. So in order to assess mechanics, as we pointed out the other day, you can perform a plateau pressure maneuver, which allows you to measure the pressure required to distend the lung during tidal ventilation. That's the driving pressure, or delta PAW shown here. And if you perform an occlusion maneuver, then you can see if the patient's making very large inspiratory efforts, which would A, reassure you that perhaps they don't have respiratory muscle weakness, and B, would probably imply that they have significant respiratory mechanical impairment still, since they need to make large inspiratory efforts to ventilate. And so these are some non-invasive maneuvers that you can perform to get a sense of whether mechanics are still a significant challenge in a weaning patient. So with that, I'll wrap it up and be happy to take your questions. Thank you very much.
Okay, great. Thank you so much, Yuan. You covered a lot. So I'm sure we'll have a lot of questions, but we already have questions about the SVT, and I tried to put several questions together, but so there are questions about how does the patient overcome the tube resistance during SVT, and is it harder to do an SVT on the vent than on the T-tube? Yeah, that's already two.
Okay, these are two great questions, and feel free to chime in, Laurent, as I answer, because I know that you're a world leader in these specific issues. But so the first thing is that the question is whether when we put a patient on spontaneous breathing trial, we need to compensate for the fact that they're breathing through an endotracheal tube. So they've got this small tube going through their airway, and they have to breathe through that in order to ventilate. And if we're doing a spontaneous breathing trial with no support, is that really a fair test? And so, of course, if the tube is way too small for the patient, if it's a large patient with a size 6, then of course we need to consider that issue. But most of the time, the answer is that the mechanics, the load applied on the respiratory system before and after extubation are very similar. And this is because the airway is actually quite edematous in a ventilated patient who's freshly extubated. And Laurent and others have actually measured the airway resistance after extubation and shown that it's just as high as it is to have an endotracheal tube in. And we've also had very good studies, including a very nice systematic review from Michael Sklar and colleagues a couple of years ago, showing that the inspiratory effort level and work of breathing are best matched by a spontaneous breathing trial that uses no inspiratory support, no expiratory support. So, when you're putting a patient on an SPT, you want to know, can they breathe without any assistance from the ventilator? And as it turns out, the best way to do that is to mimic the respiratory mechanical conditions they'll experience after extubation, and that's with minimal support. And the other question is it easier through a T-piece or on the ventilator? And the answer is it's really very similar these days, because modern mechanical ventilators have very low resistance circuits. And I don't know, Laurent, if you want to comment on that further, but there's probably no significant difference mechanically between being on the ventilator and being on T-piece.
No, and I think there are old data, and when I say old, I think I produced some of this data using the old ventilators or ancient generation of ventilators, which really were imposing some work of breathing. With the modern ventilators and with their bias flow and their flow-by circuits, the added work is really minimal. And in addition, even if we say zero pressure support, they deliver a little bit of pressure. So no breathing through the ventilator with 0, is not imposing any additional work. Okay, so there are also several questions about sedation. So there is one about a patient on high dose sedation, do you do sedation vacation by abrupt stop of sedation or halving sedation? And there's also a question about what do you do with sedation during SBT?
Okay, so these are really thoughtful questions, and sedation is a really important piece of this whole puzzle of getting off the ventilator that unfortunately I just didn't have time to get into in a course that's supposed to be specifically about mechanical ventilation. But the truth is we can't really separate our ventilation strategy from our sedation strategy. And this is because sedation reduces respiratory drive and thereby reduces a patient's ability to be separated from the ventilator. So there are multiple different ways of trying to minimize sedation, and trials have tested a daily sedation vacation approach, or what's called a spontaneous awakening trial, and that's been shown to accelerate liberation from mechanical ventilation. On the other hand, there are also trials that suggest that a very carefully titrated sedation carefully titrated to specific targets may also accelerate liberation from the ventilator. So, and sometimes there are concerns that a patient may not safely tolerate sedation vacation. So, you know, patient selection is important when planning such a thing. But the point is that we want to try and minimize exposure to sedation as much as possible, get the patient breathing, have them awake and calm and interactive. And so in a patient on an SBT, I would not want them to be on any sedation at all, because that would increase their risk of failing. Sometimes patients have significant agitated delirium, and that can be a barrier. And in such cases, a drug that spares respiratory drive, like dexmedetomidine, can be quite useful to keep a patient calm during an SBT. And then after the endotracheal tube is removed, you probably will actually be able to wean the dexmedetomidine, because the endotracheal tube itself is driving some of the agitation. So that would be a basic response to that question. But you know, there's a lot to say about sedation management that we can't get into here.
Okay, great. We have a series of questions about the hemodynamic aspect, and you insisted on the importance of that. And there's an interesting one which say, if we do an SBT on ZIP, should we reduce pressure to ZIP quickly or gradually and let hemodynamics time to adapt to ZIP?
That is an interesting question. So probably if you let me think about it. In general, I would say it doesn't matter if you've already met readiness to wean criteria and your PEEP is no higher than 8 to 10 to begin with, then I think it's safe to immediately go to a spontaneous breathing trial. And whether you reduce it gradually over a few minutes or go straight to zero, when you get to zero, the load on the heart in terms of afterload is going to be increased by the patient's inspiratory effort. So eventually the same hemodynamic effects will develop, even if they do develop more slowly. So just doing it gradually is probably not necessary. Now, in a patient with lung injury on higher PEEP, there are recent observations that suggest that dropping the PEEP dramatically can actually induce acute pulmonary edema through this mechanism that can exacerbate lung injury. And so we would want to avoid such abrupt drops in airway pressure. But in a patient who's recovering, meets readiness to wean criteria, this is less of a concern. And how often do you use inotropes, inodilators in patients with weaning-induced pulmonary edema? Do you trial diuresis first, and if that fails, add inotropes? Great question. So diuresis is always the automatic right answer in a patient who's in the weaning phase of mechanical ventilation. And certainly having a more negative fluid balance is clearly associated with a shorter duration of ventilation and greater weaning success. The issue of what to do when aggressive diuresis fails, well, I think the most important piece is to ensure afterload reduction. And so In fact, that's what you can do pharmacologically with ACE inhibitors if the patient's renal function will tolerate, or with hydralazine and nitrates. But aggressive afterload reduction would be my primary strategy to compensate for the physiological hemodynamic impairment from weaning mechanical ventilation. And if you have to put a patient on an inotrope in order to get them off the ventilator, then they're probably not ready to be liberated from the ventilator yet, and you need to rethink what's going on with their heart and potentially have consultation with a cardiologist or heart failure team.
And can you liberate the patient from control mode to extubation directly without SVT or TPs?
That's a great question. So the answer is very rarely yes. And the reason I would say that is because basically all of the assessment that we're doing here, readiness to wean criteria, spontaneous breathing trial, are basically changing your beliefs about the patient's probability of being liberated from the ventilator. In Bayesian statistics, we call this shifting around your prior. You're trying to decide whether a patient can safely get off the ventilator. If a patient comes out of the operating room freshly post-op, and they had surgery, they did very well, and they have no particular reason to think that they're going to do poorly or require ventilation in the 24 hours following, then very often those patients can be extubated immediately, just like they often are in the operating room. And this is simply because your prior belief that the patient doesn't need ventilation is very, very high. And in general, though, when a patient admitted to the ICU who developed respiratory failure, we need to convince ourselves that the patient's ready to be liberated from the ventilator. And this is just because the consequences of extubation failure, which I didn't really have a chance to talk about, are significant. It's a huge setback for the patient. There's some evidence that it may exacerbate or contribute to subsequent multi-organ dysfunction. And so we want to try and minimize that risk as much as possible. So do you need to be in pressure support in order to undergo a spontaneous breathing trial? Absolutely not. You can do a spontaneous breathing test from any mode of mechanical ventilation, provided the patient's triggering the ventilator and they meet the weaning criteria otherwise. So that would be my answer to that question and general approach.
Okay, great. So we have a lot of questions. We are arriving close to the end of the session. So maybe we have a series of questions about the cuff leak and what you do when there is no cuff leak and you give steroids. Can we still extubate the patient? And also some questions about using high flow and NIV after extubation when you do it, and whether it's a problem not to do it, for instance, in COVID-19 patients.
So in general, if a patient has no cuff leak and I have a very high index of suspicion that they do have tracheal edema, they've been on the ventilator for many days, and if they fail to improve with diuresis, then I'll consider a short course of steroids. That's my personal approach. There's a number of different approaches based on the current literature, but just in the interest of trying to minimize exposure to steroids, I try diuresis first to reduce the edema. The question about high flow nasal cannula after extubation, well, this is certainly proven to be a useful technique for minimizing the risk of reintubation, even in patients at relatively low risk of reintubation. In patients with COVID-19, there is a role for high flow nasal cannula, but because of the concerns about generating or exacerbating the spread of droplets in the room, I think it has to be used with great caution, and probably have them in a room, negative pressure room, where you can properly isolate them, make sure that you're using appropriate PPE, etc. But the guidelines for the Surviving Sepsis campaign do recommend the use of high flow nasal cannula for the acute respiratory failure portion. So if you are concerned, you could probably reasonably consider using it in patients with COVID-19. our own practice has been to not extubate the patient until we're really confident that they will do well post-extubation. And that means, in general, we don't need to resort to using high-flow nasal cannula.
Okay, thank you so much. Maybe the very last one, and I'm sure you will enjoy it, is do you routinely use inspiratory muscle training exercise in slow to win patients?
So I think we probably need more large clinical trials to confirm that the intervention accelerates liberation from mechanical ventilation. I'd say there's a number of smaller trials in the literature that may suggest that it's very promising. I think we need a good clinical trial, good multi-center clinical trial to confirm this. I personally use it in patients who are having difficulty weaning from the ventilator, where I've demonstrated diaphragm dysfunction, and I think that there's nothing else that can be fixed. And it's very, very easy to do, and you can immediately see the improvements in respiratory muscle strength in a matter of days often. So I think it's a very useful intervention that probably is going to play more of a role in the future for these patients.
Okay, thank you very much, Yuan. So I want to thank all of you who attended. I have to say it's a little bit frustrating for us because we don't directly see you, but we see clearly a lot of interest in the many questions we receive, and we hope you enjoyed these sessions. As already said, we will put everything online. Maybe just wait for early next week, or maybe the middle of next week, the time we make sure everything is well and in a good format. As already said, maybe the central website where you can find different information is criticalcarecanada.com, and you will see then a link to our mechanical ventilation course in June, which will be also online, and the different activities. Again, hope you enjoyed these sessions, and you will find it useful, and please don't hesitate to send emails, messages, feedback, good and bad, about what you enjoyed and what you did not. And I wish you a good night, and stay safe. Bye-bye.
All right, take care. Bye-bye.